Hi, everyone. Apologies for the technical issues on our end, but we are back now. I'm Matt Parsons with MedStar Health. Welcome back to our Facebook Live broadcast. It is February, it is Heart Month, and it is Valve Disease Awareness Day. According to our partners at the Alliance for Aging Research, nearly 11 million Americans are affected by heart valve disease, but 3 out of 4 Americans actually know very little about this condition. We are here to change that today. With that, I would like to welcome in our panel, Dr. Lowell Satler, Director of our Cardiac Catheterization Lab at MedStar Washington Hospital Center, as well as Toby Rogers, the Scientific Lead for our Structural Heart Disease Program. We are, of course, talking about valve disease, the symptoms, the treatments, as well as the risk factors. And we're going to be taking your questions as well. So if you have any questions for our panel, please submit them in the comments, and we will be sure to answer those for you. Gentlemen, thank you so much for rejoining us, I should say, today. Dr. Satler, it is a bit troubling when we talk about how few people know about heart valve disease. So why don't we start by having you tell us exactly what heart valve disease is?
Thanks, Matt. The heart has 4 chambers. It has 4 valves, and flow in the heart is typically in one direction. When one of these valves gets narrowed or leaks, that can result in a reduction in flow through the heart. And when there's a reduction in flow through the heart, the patient would have symptoms of heart failure, and this can occur very precipitously, or more likely it can occur over a long time and can be very misleading in that the patient doesn't feel quite right, but will have some of the symptoms that Toby can actually describe shortly.
And, might as well give you my job here, because that's exactly what I was going to ask Dr. Rogers about next. So, Dr. Rogers, great lead-in from your colleague there. Tell us a little bit about the symptoms for heart valve disease.
Well, thanks, Matt. And the truth is that there are quite a wide variety of symptoms that can be caused by heart valve disease, but by far the most common is shortness of breath. So patients will typically first notice this when they're being active, trying to do, more sort of physical activity. They'll say, I just get more breathless than I used to be. And as the heart valve disease progresses, it can become more and more prominent to the point that you're short of breath just doing very minimal activities like getting dressed or washing yourself. But there are other symptoms that are associated with heart valve disease as well, including lightheadedness, dizziness, even blacking out or fainting, and chest pain as well. And so really there is quite a spectrum, and any one of these can be caused by underlying heart valve disease. And then finally, there are substantial numbers of patients out there who don't have any symptoms in their heart valve disease. And that may be because it's very early in the disease, but also it can be that you can have significant heart valve disease and not know about it, in which case that's more typically diagnosed by your physician when you're having an annual physical and they listen to your heart with a stethoscope and they'll hear what we call a heart murmur, which is an abnormal sound of blood going through the heart valve. So a wide spectrum from no symptoms at all the way through to very debilitating symptoms. But again, by far the commonest is shortness of breath.
So let's stick with shortness of breath here, because that is the most common symptoms. When you talk about shortness of breath, lightheadedness, general fatigue, can any of those symptoms sort of mimic other heart conditions that you'll see patients for?
Most definitely. Those symptoms are not specifically related to a valve. They can be due to other cardiac conditions, such as the development of coronary blockages or coronary artery disease. And they can be seen with other problems as well, lung disease, et cetera. So it's not specific, and that's why it's important when you're having those symptoms to seek medical attention so that the symptoms can be correlated with the right disease process.
And something else that caught my attention from that previous question was when you talked about patients who have no symptoms, who may just be going for their annual physical. So if a primary care physician does detect a heart murmur like you discussed, does that normally prompt referral to a cardiologist? How does that process go?
I'll take that one. So that's usually the pathway that will happen. So once they pick up on a murmur, they'll send you to see a cardiologist who will do some more advanced tests, and we can talk in a moment about the different tests that can be done. But the stethoscope is a great way of picking up on a problem, but it's not a great way of diagnosing the severity of a problem or necessarily pinpointing exactly what the problem is. So more tests are typically required.
Gotcha. So Dr. Satler, let's go back to you. Can you talk about some of the risk factors that are associated with heart valve disease?
Sure. Well, the most common one is age. You know, the valves open and close with each heartbeat. So if you talk about 60 beats per minute and then multiply that times the number of hours and the number of days, you add up to a couple of billion beats very quickly. And that wear and tear on the valve can either cause it to become narrowed, particularly if calcium forms in the leaflets, or it can be incompetent. But there can be other specific structural damage to the valve that can occur with a heart valve infection. Sometimes if you have a heart attack, it can stretch the valve or distort it so that you can have a leak. Sometimes you can be born with a mildly abnormal heart valve that over time, due to wear and tear, becomes either narrowed or incompetent. So those are the major ones over time.
And Dr. Satler, when you refer to age, what is the age that you typically see this in patients?
So generally over the age of 65, in fact, probably if you look at the age of 75, 10% of all adults have some form of valve disease. So it's very frequent, particularly as you're older.
All right. So let's talk about how the two of you diagnose heart valve problems. Dr. Rogers, let's start with you. Discuss the diagnostic process with our listeners here.
So just focusing in on the heart side of things, the first test that we typically will do is an ultrasound scan of the heart, which is also called an echocardiogram. And that's a completely harmless test using sound waves with a probe on the front of the chest that we use to look at the different heart valves, look at the different chambers of the heart to see how the different components of the heart are working. And is usually the first way that we actually pinpoint, what is the valve that's the problem, how bad is it? And that starts to point in the direction of treatment, which I know we're going to talk about later. It's also important, like Lowell said, to remember that not all of shortness of breath is caused by heart valve disease. And so, we'll often do other tests like chest x-rays and other things like breathing function tests, if there's any question as to whether the symptom could actually be caused by something else, such as a underlying lung problem. But again, focusing on the heart, the echo is usually the starting point.
Gotcha. Dr. Satler, can you talk about any of the x-rays that we might use in helping diagnose heart valve?
Once the echo is completed, the doctor can escalate the series of tests to include something known as a cardiac CT, which allows us to look at the valves and the heart chamber dimensions. It could include a cardiac MRI, which looks at flow through the heart. It could include a cardiac catheterization, in which we look at not only the valves, but also the blood flow in the arteries in the heart. So it all escalates depending on the severity and what is actually found with each previous test. And sort of one of the things at MedStar is we have sort of a coordinated imaging team that works together very vigorously to coordinate the tests and to escalate them appropriately and integrate the results of all the tests. And if you are participating in a valve evaluation at a heart valve center, generally there are several different types of doctors that are involved with the integration of the care as well as the assessment of all of the studies to come up with the appropriate diagnosis. And it does take specialists in echocardiography. It does take specialists in CT and cardiac MR and cardiac catheterization to help integrate those studies and come up with the right diagnosis.
And do you feel that that sort of interdisciplinary approach here at MedStar Health is beneficial for the patients?
Yes, it definitely streamlines care. We have a lot of expertise in all of these different areas. And Toby's really an expert in some specialized procedures that help us manage some of these patients with advanced heart failure. So it's really both the imaging tools and the doctors and the integration of the service team that allows for really better patient care.
So Dr. Rogers, let's talk about some of these treatment options for heart valve disease. How are you treating people who come to our hospital and others throughout the MedStar system with valve disease?
Well, the first step is always to work out, obviously, which valve is the problem, what is the problem, and then how severe is the problem, how far in that disease progression is the individual patient. Some patients will diagnose them with mild or moderate valve disease, and actually the best thing to do at that point is absolutely nothing, and just to sit tight and evaluate them, with scans, every 6 months, every year, and see if it's going to get worse, and then maybe at some point in the future they need treatment. But for those patients who are very symptomatic and in whom the valve disease is bad enough to warrant treatment, then really there are only two options. There is no medication that's going to make your valve disease better. And so it's a mechanical problem. It requires a mechanical solution. And in the past, the only option really available to us was open heart surgery. So it was either to go in with stop the heart from beating, open the chest, and then either repair or replace the valve. And nowadays we have some catheter-based treatments, which mean we can do it through little tubes going through the groin, through the wrist, to repair or replace the valve without stopping the heart, without opening the chest. And increasingly, we're going down that road because the recovery is so much faster and it's so much less stressful to the patient's body.
And Dr. Satler, can you talk about TAVR and sort of what that procedure entails and, some of the benefits for as far as like the patients go?
Yeah, so there's two valves that we focus on. One is the aortic valve, in which we're talking about TAVR, and then one is the mitral valve. So let's talk a little bit about the aortic valve first. Typically, there was just surgical aortic valve replacement, otherwise known as SAVR. But about 10 years ago, a series of investigators looked at different options to manage aortic valve disease using a percutaneous approach, meaning non-surgical, going through the leg artery. And ultimately what happened is a valve was developed that was crimped on a small balloon, and that was placed through the leg artery all the way into the heart and inside the diseased valve. And then it was released. And that procedure is known as TAVR. And so for aortic valves, we have TAVR, we have SAVR, which is surgery. And really, there's no good medical therapy. For the mitral valve, it's a little bit more complicated, but again, you have surgery, and there's a whole new series of tools that are being developed to work with the mitral valve where it's predominantly leaking, in which clips are placed on the valve or even a new valve is placed in the mitral valve location. So we, again, have surgery, but now these new percutaneous therapies for both the aortic valve and the mitral valve.
And obviously, we take treatments patient by patient here, but Dr. Rogers, is there anybody who maybe wouldn't be a candidate for a minimally invasive procedure like TAVR?
Yes, there are some patients in whom, for example, they're very young, and the best treatment is to replace the valve with what we call a mechanical valve, which is a metal valve, because that will last them their entire lifetime. All of the catheter-based valves that we use for TAVR are made of tissue, just like some of the surgical tissue valves. And we know that those will last 10, 15 years maybe, but not beyond that. So if you have, for example, one of the birth defects that Dr. Satler mentioned earlier that can cause premature valve disease in your 30s and 40s, then you really ought to have a treatment that is going to last you a lifetime, and that's still surgery. And then we still see some patients, even more older patients, in whom we maybe would prefer to use the minimally invasive catheter-based treatment, but there's just something about their valve, their individual anatomy, that just doesn't fit right for one of the catheter valves, and surgery is still a great option for those patients.
And for those who are candidates, can you discuss the benefits of TAVR in terms of shortened hospital stays and quicker recovery?
Well, you've hit it right on the head. The outcome is similar to surgery, but what the patients really like is no general anesthesia. It's done under local, and in hospital duration of between 1 to 3 days, and then pretty fast recovery at home. Over 85 to 90% of all patients who have this valve procedure known as TAVR can go straight home and don't need extensive rehab. And so that's the reason why most patients like it. But as Toby says, it's very individualized. You could have one 65-year-old who'd be a perfect candidate for a TAVR, and one right next to them that looks identical, but may have some anatomical constraints that make it more difficult to do TAVR. Excessive calcium, something about the size of the aorta, something about the placement of the arteries around the heart that make it difficult to offer TAVR. And in that case, we would think about SAVR. Everyone would prefer a less invasive procedure, but that's the reason why a multidisciplinary heart valve team is necessary to make sure that we're giving the best treatment to the patient to optimize their outcome. So it doesn't mean TAVR for everyone.
Sure. So we obviously see a lot of heart patients here, both at the hospital center and across MedStar Health. What are the benefits for a patient to come to a high volume center like ours, where we've been doing these procedures for quite some time?
I think a combination of both experience and a lot of resources to help sort out the intricacies that would make one patient better for TAVR or SAVR. Or in the other spaces for the other heart valves as well, we have the ability and we have tools to manage different types of degrees of mitral regurgitation, for example, the other valve. So we can give a pretty comprehensive overview and have a lot of therapies that would be specifically helpful for a patient.
And some of these are still relatively new technologies, particularly targeting the other valves like the mitral valve, the tricuspid valve, the pulmonary valve. And the truth is that these treatments are only available in very specialist centers. And sometimes that's because they're only available in the setting of clinical trial because they're that new that they're still being tested. And so one advantage of going to a big center like the hospital center is that not only will you be evaluated by a team that has all the experience and expertise, but they may also have access to newer technologies that you simply won't be able to get at smaller hospitals.
And that's a perfect segue into our next question. Let's talk about some of those newer technologies. We've talked about kind of where we were and where we are. How about where we're going? What do you see on the horizon as far as treatments for heart valve disease go?
Well, we see a general switch over to more percutaneous therapies that is minimally invasive, like TAVR. We have not only problems with the aortic valve being narrowed, but we also have aortic valves that are leaking. And the current TAVR valves, most of them, are not good for a leaking aortic valve. They're only good for a narrowed aortic valve. And now we have access to new protocols that have a new type of valve, which would be specifically useful for the management of aortic regurgitation or a leaking aortic valve. Toby's actually developed a new technique to manage a leaking mitral valve. Maybe you could talk about that, Toby.
Yeah, so as we discussed a little bit earlier about the mitral valve is definitely more complicated than the aortic valve. And most patients with a leaky mitral valve, actually the problem is the pumping chamber of the heart that's a problem. And the mitral valve is almost like the symptom of the weaker heart muscle. And so there are a number of devices that have been developed to help improve and reshape the pumping chamber of the heart that impacts the leaky valve as well. And so one of the devices that we are currently testing in a clinical trial here at the hospital center is almost like a string or a lasso that goes around the valve and tightens it down to improve the function and at the same time improve the pumping of the main pumping chamber of the heart, the left ventricle. And so again, sort of to answer your question about where does the future lie, I think that more and more devices and technologies are going to be developed to help with this problem of heart failure, which is an even bigger problem than heart valve, but often goes hand in hand with heart valve disease, which is patients who have a problem with the muscle of the heart, which isn't pumping very well. And with some of these tools and devices that improve the flow through the valves and improve the pumping of the chambers, we can really help with their symptoms.
That is very fascinating, and thank you for sharing all of that. It's really great to see, we have all these great treatments here, but we're constantly looking for better, and awesome to see you guys are on the cutting edge of heart care here at the hospital center and across MedStar Health. So let's talk about really what we've been talking about for pretty much the last year, and that being the pandemic. Obviously, we have not shut down during COVID, and we have been, in fact, busy as ever at our Heart Institute here. So to the both of you, one of the messages that we really want to get across to people is how critical it is for them to maintain their heart care during these difficult times. So how important is it for people not to delay care and making sure that they are coming in to get their evaluations, because we don't know what might happen in the future with them?
Yeah, no, it's very important. In fact, it can be life-threatening for the patient. When COVID began, a lot of the patients with chest pain and other types of heart disease besides valvular disease didn't want to come to the hospital. And we saw a much higher incidence of out-of-hospital deaths as a result of that. So I don't think you should be delaying care. I don't think you should worry about coming to the hospital. Coming to the hospital is safer probably than going to Giant, and people do that every day. So they've taken a lot of special precautions for safety, and I think it's an environment where patients don't have to worry about coming to for their care. But delaying care can be life-threatening and may even be devastating, for not only for coronary artery disease, but also for valvular heart disease. But we definitely have seen concern regarding patients with this, and we can only reassure them that the hospital remains a safe place to come.
Dr. Rogers, anything you'd like to add to that?
No, I think Lowell has said it all, that heart valve disease never gets better on its own. It only ever gets worse. And so delaying care potentially means that when you eventually do go to have a treatment, you're sicker and not as well prepared in order to undergo the treatment. And then the final thing I just add is that it's not specific to heart valve patients, but when you're eligible and able to get a COVID vaccine, it's probably a good idea to do so.
Excellent. And I would certainly echo that, as I'm sure everybody here at the hospital center would as well. So we're going to go to some audience questions now. Thank you to those of you at home for tuning in, and really appreciate all the great feedback we're getting here. So first, from Martha, can exercise, proper diets, etc., correct or rebuild valve problems?
So they're all important for everyone, whether you have a valve problem or not. But typically, over time, as Toby had said before, they generally get worse. And there's not really a good solution when you have a mechanical problem with exercise. It's important to do, but I still think that you need to be seen by a healthcare professional to guide specific therapies and make specific recommendations for the individual.
And another question from Martha. She wants to know if the nuclear injection test helps detect or show heart valve damage.
I can take that one. So the nuclear scans are typically used to look for blockages in the heart arteries. We don't use them in the sort of heart valve assessment.
Okay, great. So let's go to one from Chanel. She's now 41, was born with mitral valve prolapse, dealt with the blacking out, increased heartbeat, and chest pain just recently. Her question is, when is it sort of alarming, or when does she need to see a doctor? And does mitral valve prolapse decrease your life expectancy?
So probably she should see a doctor soon from the symptoms that she's describing. It's not an emergency. Mitral valve prolapse doesn't necessarily change someone's life expectancy. It can be seen in up to 20% of all patients. So it's just a degree of it and whether it's causing symptoms. So for that particular patient, I think it would be best to see a healthcare provider. And they probably would do a physical examination, as Toby had mentioned before, and then escalate it to an echo to determine whether or not the valve is leaking, or is there a significant amount of movement of the leaflets. And once that's obtained, with the chest pain background, it may be worth getting some sort of a stress test. But that's where it would be important to link with a healthcare provider.
Absolutely, because these are all symptoms that we've talked about. So Chanel, I hope that was helpful for you, and hope you're able to get in for an appointment. So Our last one comes from Lois. She would like to know, Dr. Rogers, we can have you take this one. What procedure would be recommended for a female patient, almost 83 years old, with moderate to severe mitral valve regurgitation?
So I think it's really important just to go back to square one and say the first thing is to get a proper evaluation of the valve. Often the scan, the echo scan through the chest wall is not, doesn't give us all the answers we need to say how bad is that valve and how would we fix it if we think it needs fixing. So the most important thing is to make sure that, that this patient get an evaluation at a center like ours. And we would probably do some more advanced tests like a transesophageal echo, which is a different type of ultrasound scan, probably a CT scan as well. But let's assume that we agree that this is something that should be fixed. And I think at the age of 83, then we would probably lean towards these less invasive transcatheter percutaneous techniques rather than open heart surgery, typically at that age. But again, it's very hard to generalize treatment options because it is so specific to individual patients.
Well, thank you for that. And thank you for everybody who has submitted questions. We actually had one more just come up here from Carla. Is valve disease more prevalent in either gender, and does it run in families? So can we talk a little bit about family history and gender here?
Well, there are types of valve problems that can be more frequently seen with other conditions. Leaky valves can be seen with certain types of vascular problems. I don't know if it's gender specific. We do see types of valve narrowings more frequently in women, such as rheumatic disease, mitral stenosis. For aortic valve disease, we see it both in men and women. And again, it's a function of the aging process.
Gotcha. Well, that will wrap up our audience question portion of this broadcast. Final question that I have for both of you, and Dr. Rogers, we can start with you on this one. So we're coming up on a year here of dealing with the pandemic, not only here in the United States, but globally. What has this experience been like for the two of you as physicians who have continued to see patients throughout all of this? And is there anybody in particular you'd like to thank, any of your colleagues who have maybe helped you out over this last year?
It's a great question, and it's been tough for us, just like it's been tough for everyone out there. I think, you said it earlier that the hospital has been open all the way through. We haven't shut down. We've still continued to treat patients. And that's really down to the dedication of all of the staff, from, the people who prepare the meals to clean the rooms, the technologists and nurses who look after the patients, and through to the doctors and all of the administrators who keep the lights on and the hospital moving. If I had to thank, anyone in particular, it would be those members of the staff who in the early days of the pandemic, when we really didn't know what was going on, stepped up and went and worked on the wards looking after COVID patients outside of their normal sort of expertise, but really stepped up to the plate. And I think we can all be really proud of what the whole healthcare profession did when tackling this global pandemic.
And Dr. Satler, how about you?
I would have to echo what Toby had said. It's been something that no one ever thought would ever happen. We never understood the complete response. There have been a lot of mistakes made along the way, but fortunately, despite all of that, I think we're seeing the light at the end of the tunnel. And by getting people vaccinated and continue to maintain social distancing, those two tools will help us recover even faster, so that maybe this time next year we can actually be live. And with
I certainly hope it'd be great to have the two of you in person, flanking me on either side. But it is 2021. We are in the middle of a pandemic still, and thankfully we have technology, and most of the time it works. So, guys, thank you so much for joining us today. I really appreciate all of the great insights, as do our viewers here who are watching. We, of course, also want to thank all of you at home, both those who submitted questions and those who just casually watched here. And we cannot leave with, of course, also without thanking our healthcare professionals here at the Hospital Center, across MedStar Health, and around the world. Thank you for all you do and will continue to do over this pandemic. Everybody stay safe out there.
Thanks, Matt.